Thiazides and their mechanism of action in the distal tubule involve a symport to sodium and chloride. Notice here, no participation of potassium. It is by blocking the sodium chloride entry into the distal tubule that we can call a thiazide a diuretic. Of course, the diuresis is really weak at this level, being that less than 10% of our sodium load is reabsorbed. Most of the job has been done earlier on in the proximal tubule and in the thick ascending loop of Henle. Nonetheless, by definition, let's say a thiazide is a diuretic. Now, one point of this diagram is to make us work on calcium reabsorption. Calcium can enter inside this kidney tubule thanks to a channel. This channel is PTH dependent. Now, PTH as a hormone is a peptide. It cannot be filtered by the glomerulus and therefore has no access directly on this channel to open it. Rather, I want you to think of PTH coming from the bloodstream on the basolateral side of this cell and working on its receptor. The receptor to PTH is actually a GS-coupled receptor, which will increase cyclic AMP in this cell, and through protein kinase A will result in phosphorylation of this calcium channel. I'm sure you are getting used to this pathway since we've used it with several GS-coupled receptors, whether in nodal cells, in muscle cells of the heart, and now here in the kidney. This GS coupling and phosphorylation of the channel opens it. Now, once calcium is inside this cell, it still faces this daunting gradient that is 10,000-fold in favor of going into the cell rather than leaving it. So to the far right of your diagram, you see the sodium-calcium exchanger pump, which, if you remember well, depended in turn on the sodium-potassium ATPase pump to actually manage to work. So here's the deal. Can you remind me, what is the real engine for this calcium to move from inside the cell into the blood? Are you remembering accordingly that it depends on the sodium gradient? Well, work it out with a thiazide. If I block sodium entry from the luminal side, what happens to intracellular sodium concentration? I'm sure you're thinking, well, if I block sodium entry, there is low sodium inside this cell. And with low sodium, this should help the sodium-calcium exchange. So that literally, providing PTH is available, there should be an increased reabsorption of calcium in the kidney in the presence of a thiazide. In a nutshell, thiazide should result in hypercalcemia. Contrast this to our loop diuretics that caused a hypocalcemia, and you now have a salient feature of a thiazide diuretic. So here is in text what drugs such as hydrochlorothiazides or indapamide, metolazone would be another one if you want to write it in here with me. These are just three of a group of drugs that of course encompasses many more members. They all share the same mechanism, and their mechanism is to classically block sodium chloride transport in the distal convoluted cell, thereby increasing luminal sodium and chloride and therefore causing diuresis. Uses are the edema of congestive heart failure, maybe the edema associated with other antihypertensive medication, but also simply hypertension. Now, you should always be leery when a diuretic is used for hypertension. That should remind you, like the loop, I bet you these thiazides also share another pharmacology to explain their antihypertensive effect. And you would be correct. Thiazides are also ATP-dependent potassium channel openers. And if they're ATP-dependent potassium channel openers, doesn't it remind you some drugs that we know as antihypertensive? You remember the drug that caused hypertrichosis? That, of course, resulted in a drug-induced diabetes? Yes, of course. It is like minoxidil or like diazoxide. And as such, thiazide is, if you want, a milder version of these drugs used in hypertension. So it is truly a drug that would vasodilate. it is also truly a drug that will potentially worsen, exacerbate a diabetic patient. So we'll keep this in mind for the side effect. Well, how about this indication? A thiazide can be used not as a diuretic, but as a drug that would help my patient who has calcium stones. I'm sure you're thinking, well, of course, if I'm causing better reabsorption of calcium in the body, then it means less calcium in the urine tubule. With less calcium in the tubule, there should be less likelihood of stones. Indeed, thiazides are actually the best drug to use in calcium stones, and oppose this to a acetazolamide-like drug that could worsen these stones. Finally, thiazides are also used in the treatment of nephrogenic diabetes insipidus. Now, this is a nice story again, and let me go back to the initial diagram. Free water, if you recall, is produced in the thick ascending loop when we retain salt to the expense of water. Free water literally refers to water that is no longer associated with salt. That is, water that can no longer follow an osmotic gradient to be retained by the body. As such, free water depends totally on ADH and its binding to receptors in the collecting duct to allow its reabsorption shortly prior to being eliminated. If ADH receptors are non-functional, as is the case in nephrogenic diabetes insipidus, then upwards of 10 liters of dilute urine per day will be lost by the patient. The whole idea then of using a thiazide diuretic in nephrogenic diabetes insipidus is literally to recombine this free water with salt. By using a weak diuretic such as a thiazide, we are not going to run the risk of exacerbating terribly the nephrogenic diabetes insipidus. And although this might happen acutely, let's not forget that within a couple to 3 days, adaptation by our kidney will result in an increased aldosterone and the potential for retaining with the salt this water that is no longer free prior to reaching the ADH level. In reality, it is also fair to think that at any other level but the one where thiazides are blocking sodium transport, there should be an upregulation so that really more water is also retained at the level of the proximal tubule, and obviously, thanks to this, less water is presented distally in the collecting duct. So by no means is the thiazide really curing nephrogenic diabetes insipidus. At best, it is a supportive management that allows the free water to be retained in spite of lack of effect of ADH. So as we go back to thiazides, well, we do have a number of side effects, and keep in mind ultimately through these electrolyte anomalies and specialties of drugs you will be able to make a distinction between the diuretics. We must remember sulfonamide hypersensitivity is an issue with thiazides, just as it was with loops, except for what drug? Ethylcrinic acid is the answer. Hypokalemia and alkalosis, identical to that observed with loop diuretics, will also plague this patient. I think what you highlight big is the hypercalcemia. Remind me, what were the effects of loop diuretics on calcium, on magnesium? Yes, indeed, it was hypocalcemia, hypomagnesemia. Here we have a drug that makes us retain calcium. It becomes a feature that is noticeable of a thiazide use. Hyperuricemia, I'm sure you recall that it's by competition between the weak acidic drugs that are thiazide and the uric acid. And hyperglycemia and hyperlipidemia. Can anyone think about how this happens? All you must think about, once again, is how is it that a thiazide lowers blood pressure? It did it through ATP-dependent potassium channel opening. Remember, just like diazoxide, minoxidil. And of course, in doing so, it can also substantially decrease insulin release from the pancreas. And by decreasing insulin release, it has a diabetogenic effect. This is why we should see hyperglycemia, hyperlipidemia, and we should avoid thiazides in patients with diabetes. Basically, thiazides, beta blockers, those are two groups of drugs that are commonly used in management of hypertension and other cardiovascular diseases that are not good in people with diabetes. As a matter of fact, what drug would be really better indicated in a diabetic with comorbid condition of hypertension? Of course, use ACE inhibitors, angiotensin receptor blockers. Finally, let's remind ourselves again of digoxin and the increased toxicity due to electrolyte disturbances such as hypokalemia.